privileged today to have as our co-host a leading light of Philippine glaucoma and of the Asia-Pacific region, my good friend and colleague, Dr. Norman Aquino.
Good afternoon, everyone. Good afternoon, Vic. It gives me great pleasure to join all of you today. For our very special learning session today, we will be highlighting corneal ectasia and its relationship to intraocular pressure measurement using the Pentacam and the CorvisST. So I am excited for everybody to hear and learn the lectures today because it is going to be very interesting, very clinically important for us to know about these things. And, considering the specialty of Vic and myself, we are really looking forward to a very productive session this afternoon.
That's right, Norman. What we have for our audience this afternoon is what you can call a confluence of interests of both cornea and glaucoma specialists, thanks to the innovations of our friends at Oculus, who are, by the way, our sponsors for this corneal imaging series.
We also have to thank for these sessions the Medical City, particularly the Eye and Vision Institute, for this opportunity of learning. To start today's episode, I'd like everybody to listen to a message from Oculus, our partner. Allow me to please introduce Ms. Trisha De Jager from Oculus.
Hello everyone, I'm Trisha De Jager, a clinical education trainer for Oculus GmbH. On behalf of Oculus, I would like to congratulate Dr. Vic and the team from the Medical City on this fantastic educational initiative. We are both honored and proud to be a part of it. One of the best known displays in the Pentacam is the Belin Enhanced Ectasia display. This display is used by many as the go-to way to screen refractive patients to detect abnormal corneas. It uses both anterior and posterior elevation as well as pachymetry progression. A newer feature to the device is the Belin ABCD staging and progression display. The ABCD staging uses 4 parameters to grade keratoconus. This staging is incorporated in the ABCD progression display, a display which monitors and detects early keratoconus progression, in many cases, way before changes in Kmax is detected. In today's episode, the CorvisST will also be discussed. The Corvis, a non-contact tonometer which includes high-speed Scheimpflug photography, measuring corneal biomechanical response, but also generating normative parameters, which is helpful in many areas of ophthalmology, one of which is glaucoma. The device records an IOP and it then calculates the biomechanical corrected IOP, which is independent of both corneal thickness and corneal biomechanics. A new feature is the BGF, a biomechanical glaucoma risk factor, which aids in the screening of normal tension glaucoma. The last topic of the day is the combination of the Corvis and the Pentacam. Raw data from both these devices is incorporated in a random forest approach, generating the TBI, or Tomographical Biomechanical Index for ectasia. A new feature is also the LVC-CBI, which monitors the stability of the cornea post-refractive surgery. On behalf of Oculus, I would also like to say a special word of thanks to all the speakers. Thanks for your time and effort in preparing for today. We would like to furthermore say thank you to EyeTV for producing and broadcasting this episode, as well as our distributor in the Philippines, HQ Ophthalmics. Then, from my side, stay safe, healthy and happy during this time. I hope you enjoyed today's episode and I'm sure you will learn a lot.
Thank you so much, Trisha. And she's all the way from Amsterdam. Now, to start our program, let's have the second part of the Pentacam instructional module. For those of you in the audience tuning in for the first time, the first part of the Pentacam module is still up on the YouTube channel. So you can access it almost anytime. Now, without further ado, I would like to introduce once again our young colleagues, Dr. Karina Samaniego and Dr. Christina Tan. Dr. Karina Samaniego is a graduate of the Ateneo School of Medicine and Public Health. She finished her ophthalmology residency at the Medical City Eye and Vision Institute, where she served as its chief resident. She has the distinction of being the first clinical consultant of the Young Ophthalmologist program of Oculus Asia.
We will also hear from Dr. Christina Tan, another graduate of the Ateneo School of Medicine and Public Health. She completed her residency in ophthalmology at the Medical City Eye and Vision Institute, where she is currently doing a fellowship in cornea, external disease, and refractive surgery. Just as her colleague, she is also a clinical consultant of the Young Ophthalmologist program of Oculus Asia. The first speaker will be Dr. Samaniego, to be followed by Dr. Tan.
Hey, thank you very much, sirs, for the kind introduction, and a good afternoon to everyone. To start this episode, we will first tackle the Pentacam's Belin Enhanced Ectasia display. So as we know, keratoconus is a bilateral, asymmetric, cone-shaped deformity of the cornea, which occurs due to progressive central or paracentral corneal thinning. Its classic appearance on corneal topography is that of an inferior steepening. The progressive thinning and steepening usually begins posteriorly and is often the first and only sign seen in cases of form thrust keratoconus. Now, as we introduced in the last episode, the Pentacam makes use of Scheimpflug images to identify vital anterior eye structures. By measuring these surfaces and their relative position, elevation maps of the anterior and posterior cornea can be produced, as well as a full corneal thickness map. The Belin Enhanced Ectasia display, or the BAD-D, was the first screening tool to utilize the data supplied by the Pentacam's Scheimpflug images to provide a comprehensive keratoconus screening tool. The combination of the anterior and posterior elevation and complete pachymetric data gives the clinician a more complete view of the structures of the cornea and allows for earlier detection and more effective screening than was possible with previous systems. Now, in order to fully appreciate the display, it's first important to understand why tomography was used instead of just topography. There's a common misunderstanding that curvature maps reflect the shape of the cornea. But the truth is, curvature, regardless of how it is generated, does not convey shape information. This is similar to the difference between the power of a spectacle lens and its shape. The power of the lens may tell you how the lens will perform optically, but it will tell you nothing about its shape, as multiple lenses of different shapes can have the same optical power. With elevation, both the anterior and the posterior surfaces can be measured, as well as lens thickness. Now, knowing both surfaces and the lens thickness, still applying it to our previous example, can allow you to reconstruct an identical lens. Knowing the distinct shape of the lens will also allow you to secondarily compute your lens power. Now, finally, because shape is more accurately illustrated using elevation, it is more precise in locating abnormalities, such as a cone in keratoconus. As we learned in the previous episode, the most commonly used reference surface for elevation data is the best fit sphere, or the BFS. Other surfaces can be chosen, and while some of these surfaces may have some utility, the lack of intuitive ease of the visual inspection of a BFS. As seen in this example, the best fit sphere best demonstrates the island of elevation in a cone compared to the other reference shapes. Now, to keep in mind, with the BFS, a larger area will cause the reference surface to be flatter and will accentuate the normal asphericity of the cornea, while a smaller area will cause the reference surface to be steeper and will mask the normal asphericity. It is therefore recommended to choose a BFS set to the central 8 millimeters of the cornea. This will mask the normal asphericity and allow easy detection of pathologic ectatic change. An 8 millimeter optical zone also provides a sufficient number of data points while still being in a range where most exams will not include any extrapolated data. So what then does ectasia look like on tomography? Keratoconus will show a positive island of elevation as the conical protrusion is above the BFS. The location of the island and its magnitude will correspond to the location of the cone and the severity of the ectatic change. Most patients with keratoconus will have, in addition to a conical cornea, a significant amount of astigmatism, and one will typically see, as in this map of the posterior cornea, a positive island of elevation superimposed on an astigmatic pattern. For refractive screening and for most clinical situations, the best fit sphere gives the most useful qualitative data. What is typically overlooked is that the BFS will be influenced by any abnormal portion of the cornea. In the case of keratoconus or ectasia, the cone or apical protrusion will have the effect of steepening the BFS, thereby minimizing the elevation difference between the apex of the cone and the BFS. What the bad D does is that it designs a reference surface that more closely approximates the individual's normal cornea by removing an optical zone of 3.5 millimeters around the thinnest location, and then comparing the actual corneal shape to this new reference shape. This will accentuate the ectatic or conical region, allowing for a clearer assessment of the ectasia. Tying all of these elements together, the Belin Enhanced Ectasia Display combines elevation-based and pachymetric data in order to give the clinician a global view of the structure of the cornea and to quickly and effectively screen patients for ectatic disease. The combination of pachymetric graphs, indices, and elevation maps with the enhanced reference sphere make possible an increased sensitivity and specificity in the screening of patients for ectatic disease. Each of these values can be evaluated against a previously determined set of normal values to assist the physician in determining normal, suspicious, and abnormal corneas. We'll take a look at the individual components of the display in the following sequence. The left-hand side is composed of 3 maps. The baseline elevation map is the BFS fit on the median of the cone. The enhanced elevation maps are those with the 3.5 millimeter optical zone removed, as we discussed earlier. And the difference maps at the bottom show the difference between the baseline and enhanced maps for both the anterior and posterior parts of the cornea. This change has been shown to be a key differentiator between normal and ectatic corneas. It's color-coded in a traffic light scheme, allowing for quick and easy visualization of suspicious and abnormal areas. The green on the difference map represents a change in elevation of less than 6 micrometers on the front and 8 micrometers on the back surfaces of the cornea, and this is the range typically seen in normal eyes. The yellow areas represent a change between 6 to 12 micrometers on the anterior cornea and 8 to 20 micrometers for the posterior cornea, and these eyes fall in the suspicious or suspect zone. The red represents areas where the elevation difference between the 2 maps is more than 12 micrometers anteriorly and more than 20 micrometers posteriorly, and this is typically seen in eyes with known keratoconus. On the upper right hand of the corner of the display is a comprehensive pachymetric evaluation. Both pachymetric values at the apex, or the point on which the exam is centered, and the thinnest point are displayed, and the displacement of the thinnest point from the corneal apex is calculated along with the direction of the displacement. Note that the pachymetric difference between the thinnest point and the apex is more than 10 micrometers in only about 12% of normal corneas, and the distance between the apex and the thinnest point is significantly higher in keratoconic eyes. The progression index is calculated as the progression value at each meridian from the thinnest point. The average of all meridians and the meridian with maximal and minimal progressions are also displayed. These parameters allow for the differentiation of a normal thin cornea versus one with ectasia, as well as of a normal thick cornea versus one with early edema. Graphical representations of the progressive thickening of the cornea from the thinnest point to the periphery are depicted in the CTSP. The PIT refers to the percent of increase in thickness from the thinnest point to the periphery. So these graphs provide the average progression derived from a normal population as seen by the central black line and the 95% confidence intervals as seen in the upper and the lower black lines. And these are compared against the patient's own data in the red line. So this will allow the clinician to differentiate again normal corneas from early ectatic disease. So corneas with ectasia will show a more rapid progression of the thickening from the thinnest point to the periphery. Or put another way, ectatic corneas thin more rapidly than normal eyes, going from the periphery to the thinnest part of the cornea. The display then creates a final D from these 5 deviation parameters. And these are based on a normative database of either myopic or normal, or hyperopic and mixed astigmatism populations, depending on which you choose. The final D then indicates how many standard deviations from the mean your patient is situated, and therefore the likelihood that your patient has ectasia. The box will be colored yellow if suspicious and red if high risk for ectasia. So let's take a look at the following examples. In this example, both anterior and posterior elevations are normal and show a typical astigmatic pattern. The central cornea has a normal thickness at the apex of 532 micrometers and shows little progression towards the periphery, causing the PTI tracing to be relatively flat. The TP is moderately displaced, hence it flashes yellow in the bad D, but the overall reading is still within the normal range. This cornea has a number of variables that fall in the suspicious area. Both the anterior and posterior elevations show small central yellow zones, and the pachymetric progression and thinnest point displacement are also in the yellow zone. Only the thinnest value at 568 micrometers is normal. The combination of these suspicious values, however, is enough to put the overall reading well outside the normal range and is therefore displayed in red. Additionally, this display warns the user that there is insufficient corneal coverage and the user should attempt a repeat image which would give the full 8 millimeters of analyzable data. This is an example of a case that was diagnosed as mild keratoconus based on the anterior cornea only. Upon analysis with the enhanced ectasia display, there are also changes on the posterior surface, more dramatic changes in the pachymetric progression, which is red at 3.70 standard deviations from the mean, and a mild displacement of the thinnest point. The combination of these, however, is well outside the normal range with a final D clearly in the red zone. So let's tie everything together now with this final example. This is a formaps refractive of a right eye that is clearly keratoconic. Now looking at the formaps of the left eye, it looks relatively normal, showing only a with the rule astigmatism and no suspicious areas of thinning. The bad display of the right eye confirms what we saw in the formaps, with the final D and all its individual parameters colored red. Now, for the left eye, while the elevation indices appear to be within normal limits, the corneal thickness and the pachymetry progression data show that the left eye may actually also be at high risk for ectasia. So what the bad D does is that it can actually help us detect these subtle changes and progression in cases that might be deemed normal using the conventional refractive maps. So in summary, the Belin Enhanced Ectasia display uses Pentacam-derived Scheimpflug data to provide a comprehensive keratoconus screening tool. It combines the anterior and the posterior elevation data as well as pachymetry for early detection and effective screening for refractive surgery patients. And it was the first screening tool to utilize this technology, but as we'll see in the succeeding lectures of today's episode, it was not the last. So this will be continued this afternoon. And with that, I thank you all for your kind attention, and I hope you enjoy the rest of what has been prepared for you today. Thank you.
Do you really know what biomechanics is and what it has to do with the cornea? It's actually very simple. Biomechanics describes how biological bodies react to outside forces. For example, pressure. A distinction is made between elastic and viscous properties. Elasticity is the ability of a body to return to its original size and shape after using force, like a spring. The more elastic a body, the better it is at doing this. Stiffness describes how much force is needed to elastically deform a body. This depends on both its composition as well as the amount of material. Viscosity is the resistance against permanent deformation. Viscous bodies can no longer return to their original state or only do so slowly. The cornea is both viscous and elastic, which means that it retains its form after being exposed to outside forces and only later returns to its original size and shape. A healthy cornea can do this relatively quickly. It's elastic and stiff. In the case of an ectatic cornea, the biomechanical properties are changed. This leads to increased thinning and bulging of the cornea. For example, laser surgery could cause ectasia. The elasticity and stiffness of the cornea therefore have a lot of importance in ophthalmology. For example, in corneal cross-linking, intraocular pressure measurement, or corneal incisions. However, the stiffness of the cornea could never be measured individually until now. CorvisST from Oculus makes this possible for the first time ever. Pressure is applied to the cornea via an air puff, and a high-speed camera records the change. The Corvis software uses this to calculate a stiffness parameter of the cornea. These data are of particular relevance for screening before refractive laser surgery. In combination with the Pentacam, CorvisST provides dual safeguarding. Patients at risk with a predisposition for ectasia that can't be detected by corneal geometry measurement alone can be detected by means of corneal stiffness measurement. At the same time, the joint analysis helps in determining if any patient can be operated on safely. On the basis of tomography, some of them would have to be refused surgery due to reasons of safety. CorvisST therefore helps you to operate on more patients safely and also reduce the risk of an incorrect decision. Oculus.
Hello, everyone. I hope everyone is having a pleasant afternoon. I'm here to talk about keratoconus progression, the ABCD grading, and progression display. We just saw from Karina's lecture the bad display, which we use for laser refractive surgery screening. So when you have detected an abnormality like keratoconus during screening, you should be monitoring for the development of progression. So you'd like to know if the disease is stable or if it's worsening over time. Keratoconus progression causes increased corneal thinning and steepening, which leads to irregular astigmatism and worsening vision. Advanced cases can also develop acute eye drops, which worsens visual prognosis even more. So since there is visual decline in later stages, we should be detecting keratoconus progression early on, even before patients develop visual symptoms. So your goal for treatment, especially with cross-linking, is to detect progression as early as possible so that you can preserve the patient's vision. The global consensus of keratoconus in 2015 concluded that progression is a consistent change in at least two of the three parameters. First is the presence of steepening of the anterior corneal surface. Second, steepening of the posterior corneal surface. And lastly, corneal thinning from periphery to the thinnest point. And these changes need to be consistent over time for you to say that there is really progression. So if you look at this Scheimpflug image, you can clearly see that the definition encompasses the anatomical structure of your cornea. So you're looking at the front and the back corneal surface as well as the thinnest point. So in 2016, Professor Belin developed the most recent classification system for grading of keratoconus, and this addresses the global consensus definition of progression. Parameters: A for anterior radius of curvature, which is taken at the 3 mm zone and centered on the thinnest point of your cornea. B is for back or posterior radius of curvature at the 3 mm zone, centered on the thinnest point. And C for corneal thickness at the thinnest location. You also have D for distance-corrected visual acuity, and visual acuity was added so that you could assess the functional aspect of the disease. So there are 5 stages, from stage 0 to stage 4. Stage 0, where patients have no disease, up to stage 4, where patients have very advanced keratoconus. So this is what the Belin ABCD keratoconus staging looks like in graphical form. Again, to recap, we have A for anterior cornea, B for the back or posterior cornea, C for corneal thickness at thickest location, and D for distance corrected. The A, B, and C parameters are automatically graded by your software, but you have to manually input the DCVA into your grading system. So when you click on this box, you can type in the patient's distance visual acuity. So this is the complete grading system shown in the red box, and this is actually the most important aspect of the display. So it helps you to visualize which part of the cornea is affected. So in this example, the grading is A2, B3, C1, and D2. A2 means that the anterior cornea is at stage 2. B3 is that the posterior cornea is at stage 3. C1 means that the thickness at the thinnest point is at stage 1. And D2 means that the distance-corrected visual acuity is at stage 2. So you can clearly see here where the problem is. And in this case, it's steepening at the anterior and the posterior corneal surfaces, with some corneal thinning and a decrease in distance visual acuity. You can see the Belin ABCD keratoconus staging in the topometric indices display, as you can see here in the red box. So after staging keratoconus, we can monitor for progression by using the ABCD progression display. And this allows you to visualize progression over a series of follow-ups. So the first thing you should do in this display is to select your baseline examination of each parameter, and this is pointed by the black arrows. So the baseline examination is usually the first one, and this serves as your baseline for comparison of subsequent follow-ups. So if the patient already underwent cross-linking treatment, you should check on the tick box below the date when the patient was treated. Is this horizontal dotted line, as you can see here, with a location symbol at the end. For laterality, you can choose which eye you want to be displayed. You just have to click on the tabs if you want the right eye, the left eye, or you can display both eyes for comparison. So the ABCD parameters are on the left side. Again, A is for anterior cornea, B for posterior cornea, C for thickness at the thinnest point, and D for distance-corrected visual acuity. So beside each parameter, you'll see the dates when the examinations were taken. So the baseline examination is at the top, and as you can see here, it was taken in 2012 and followed by your succeeding examinations. So it's shown in different colors so that you can clearly distinguish them, and you can have up to 8 examinations per parameter. You'll also see here the values per examination and the stage of your keratoconus. So here in this example, the anterior surface, which is A, is graded as stage 2. So if you look at the black arrows, you can easily visualize and compare how much the values have increased over a series of follow-ups. So to determine if there is significant progression, you have to look at 2 sets of confidence intervals, and you will compare your values with these confidence intervals. So the green represents your normal population confidence intervals, and the red will represent your keratoconic population confidence intervals. And it's important to measure both normal and keratoconic populations And this is because values in very early or subclinical keratoconus, like in stages 0 or 1, are more closely related to values seen in the normal population. So it would be better to compare this group to normals instead of comparing it to the keratoconic population, which have much higher values. On the other hand, those patients with more advanced keratoconus, like stages 2, 3, and 4, will more likely resemble values of the keratoconus population as compared to your normals. So the normal population confidence intervals will appear as green flags, as you can see pointed by the black arrows. So the 80% is presented as a dashed line, while the 95% is presented as a solid line. In this example, you see in the box that the A parameter or anterior cornea has a grading of stage 0. So like we said earlier, since very early or subclinical disease more likely resembles normal population values, so in this case, we will use normal population confidence intervals to determine if there is progression. So we see here the baseline examination in 2012 as pointed by the arrow. When you compare it to the second visit in 2014, you can see that the values already hit the 80 and 95% confidence intervals. So to simplify things, this just means that the possibility or probability of you having significant progression on the anterior surface is 95%. Next, you have your keratoconic population confidence intervals, and they appear as red flags. So same as the normal population, the 80% is presented as a dashed line, while the 95% confidence interval is a solid line. So in this example, you see in the box that the B parameter or the posterior cornea has a grading of stage 2. We know that advanced disease will more likely follow the keratoconic population. So in this case, we will use the keratoconic population confidence intervals to determine if there is progression. So again, we have the baseline examination in 2012. And when we compare it to the second visit in 2014, you can see that the values already hit the 80% confidence interval of the keratoconic population. Again, to simplify things, this just means that the probability of having significant progression on the posterior surface is 80%. So if the values were also to hit the 95% confidence interval, then the probability for having significant progression is 95%. You will also notice in the display that only parameters A, B, and C have confidence intervals. And these are encircled here. And the D parameter or distance-corrected visual acuity does not have any of these confidence intervals. So you will also notice that the confidence intervals are not available after cross-linking treatment. So they stop before the treatment symbol, as you see here in the A, B, and C parameters. So Professor Belin is currently doing a study that involves these post-cross-linking confidence intervals, and this will be part of the next development of the progression display. You can also choose to isolate the confidence intervals. So you can click on the green box if you only want to see the normal population. And if you click on the red box, you will only see the keratoconic population. So here at the bottom are the other parameters like your ABCD classification, the BAD-D, and Kmax, and others for easy visualization. So you can use this to look for changes over time. For example, you can see how the Kmax values increases from 50.2 at baseline examination to 51.2 on the third follow-up. So to summarize, let's look at a case. We have a 29-year-old male who is asymptomatic with a VA of 20/25 on the right and 20/20 on the left eye. So this is the left eye of the patient. This eye has subclinical disease, as you can see here, with a grading of A0, B0, C1, and D0. So for of anterior and posterior cornea, it's stage 0. Thickness at thinnest location, or parameter C, is at stage 1, and parameter D, or DCVA, is at stage 0. So in short, only corneal thinning was noted at baseline for this patient. So if you look at the anterior surface, notice that there is significant progression from baseline, hitting both the 80 and 95% confidence intervals. And remember that since this is a subclinical disease, it more closely matches the normal population confidence intervals. For the posterior surface, you can also see very significant progression from baseline, hitting all confidence intervals, both normal and keratoconic. So this is very significant progression. For the right eye as well, we also saw a similar progression on the posterior surface, as you see here, hitting the 80% confidence interval for the keratoconic population. So to summarize, progression was seen on the anterior surface of the left eye and the posterior surface of both eyes. Since there was significant progression, cross-linking was done bilaterally. To summarize, for patients with keratoconus, you want to detect progression early enough so that you can preserve the patient's vision. When you see significant progression, that is already an indicator for you to start treatment, particularly with cross-linking, so that you can stop the progression. So lastly, the display is very helpful when you have patients who are hesitant to undergo cross-linking. So they still have good vision and they're not really convinced that they really need this procedure. You can use this display to show them that there's progression happening on their corneas, and that's why they need to do cross-linking surgery. So finally, the early bird gets the worm. So early diagnosis, you will be able to treat the patient and preserve the patient's vision. Thank you very much. Time and attention.
Thank you very much, Tina and Karina, for very clearly explaining to all of us what corneal ectasia is and for teaching us how the Pentacam can be used to help the clinician with their very special cases. You both made it look and sound so easy. Congratulations.
You know, Norman, I can't help feeling envious today's young doctors. We have come a really long way from when we used to diagnose, when we were residents, keratoconus with just a slit lamp and a keratometer.
Correct.
And
Correct.
I'd give a lot to have these toys when we were residents. My only fear is maybe we wouldn't have understood them.
I agree with you. I mean, thank God for technology. Thank God for making technology help make what we do safer for our patients, Yes.
That's right. And let me remind our audience that these lectures are designed to give the general IMD a quick start. So for a more in-depth discussion, Oculus has provided us with a support line via Viber, and Dr. Samaniego and Tan can actually address all your in-depth concerns. Now, to segue into the next segment, you might be wondering why a cornea guy and a glaucoma guy are co-hosting a cornea show. Now, you have to realize that the technology we're going to discuss next has its origins in air puff tonometry, which is still very much used in checking IOP. And what the genius of Oculus is to put in a high-speed camera which was able to detect a dynamic change or to image dynamically the cornea as it was indented. So our next guest this evening has very extensive experience using this machine, the CorvisST, in his glaucoma practice. He is, and I hope I get this right, Dr. Win Hong Phuc, who lectures in ophthalmology at Ho Chi Minh Medical University and practices at the University Hospital as well as the Cho Ray Hospital.
Ladies and gentlemen, it is our pleasure to now give the floor to Professor Nguyen as he takes us through corneal biomechanics in glaucoma management.
Good afternoon, everyone. Thank you for Dr. Aquino for your kindly introduction. We all know that corneal biomechanics is very important in corneal disease, but we also know that recently corneal biomechanics play a very important role in glaucoma management. And today I'm very happy to be here to share my knowledge about corneal biomechanics in glaucoma management. we know that IOP is very important factors in glaucoma management. We can use IOP to screening the disease, to diagnosis, to set a target pressure, to make a treatment decision, to follow up, and for prophylaxis. We also know that Goldman tonometer is a gold standard in IOP measurements for a long time. But in 1957, Professor Goldman also said that the most accuracy of IOP Goldman tonometer is with the mean central corner thickness about 500 micrometers. So at that time, he also said that there's a relations between the corneal properties and the IOP. So what is the real IOP? I mean, what is the IOP? The pressure that depress the sclera. What's the IOP inside the eyeball? We know that Goldman tonometer just measure the pressures indirectly. This method is based on the imperfect law. The law said that the pressure inside the eyeballs is the pressure that's depressed an area of the cornea. But the laws assume that the cornea must be infinitely thin, must be perfectly elastic, and must be perfectly flexible. The thickness of the corneas, we also know that related to the IOP for 20 years recently. But the elastic and the flexibles of the cornea, the biomechanical of the cornea, how it's affect to the IOP is unclear. This is the most important study in 2002, ocular hypertension study. The study said that CCT is strongest risk factor for glaucoma progressions. But when we apply this study to the clinical practice, I see we have some limitation. First, we see that in some patients with the low IOP and even normal optic CCTs, the glaucoma still progress. And in some patients, even in one patient with the same IOP, with the same CCT, we still see the progression of glaucoma asymmetry between two eyes. So we still have two questions. What is the real IOP? What is the real IOP inside the eyeball? What's the pressure affect the optic nerve? And the second question is, how is the ability of orbital wall to suffering from the increase of pressure, especially laminar cryoprosel? And as Dr. Camara says, thanks for technology. Now we have something new. This machine is the first time we measured the biomechanical of the cornea by using air pressure to depress the cornea, and then they measure every index of the cornea when it's deformed. We have three main stages of deformation. The first stage is the first applanation of the cornea, and then the cornea is at highest concavity. And after that, it's recovered to the normal. We have second applanation. Because CorvisST use ultra high speed camera, so it can get every movement image of a cornea, and then it's measured and provide many parameters, important parameters. This is how CorvisST work. They measure DCR parameter, dynamic corneal response parameter, in three times: the time of deformation, the velocity of deformation, and the amplitude of deformation. And in clinical practice, for easily to application this parameter to the clinical practice, they create three parameters. We call it DIOB, SPA1, and BCF. And in the next slide, I will explain how it works. This is the first explanation stage. We have 4 parameters. A1 length. A1 length is blue arrow. This is the length of the corner at the first explanation. A1 time. A1 time is the time from the normal position to the first explanation. A1 velocity is the velocity of cornea to deform. And the A1 deformation amplitude is the distance from the normal position to the first explanation. In a stiff cornea, the time may be slower, the velocity may be slow, and the deformation amplitude may be small, but the length of the first explanation may be longer because the central cornea and the peripheral cornea are deformed at the same time. This is the highest concavity stage. We have a time to deform the distance from the normal to the highest concavity. We call it deformation amplitude. We have peak distance. Highest concavity is the distance of the blue arrow, the distance from the 2 peaks of the cornea as the highest concavity. And we have the radius. This is the radius of the white circle. So in the stiff cornea, because the cornea is flatter, so the radius will be longer. At this stage, we also have a special parameter. We call it DA ratio 2 millimeter. This is the ratio between the deformation amplitude as the cornea aspect, the red arrow, and the deformation amplitude at 2 millimeter nasal and temporal from the aspect, the green arrow. In a stiff cornea, the central cornea and the peripheral cornea will deform at the same time. So this ratio will be small. And in the softer cornea, this ratio will be large. Very interesting. And finally, the recover state. We also have the second explanation with the same parameter. A1 length, A2 length, A2 time, A2 velocity, and A2 deformation amplitude. This is the research from China and very interesting. I really like it. I like it very much. They watch the patient, the normal tension glaucoma. They compare both eyes of one patient, and they realized that in the better eye, with the same IOP, with the same central corneal thickness, but has the different significance is biomechanical. This is for the parameter is very different in both eyes, and they conclude that the stiffer eye has a better eye. That the eye has the glaucoma in the early stage. Professor Masato Matsura from Japan also surveys about the relation between the visual field progression and the biomechanical. She found the mean total deviation from Humphrey perimetries is related to the A1 time, A2 time, A2 length, and highest deformation amplitude. So she said that we should measure the CST, CorvisST with the visual field progression, visual field perimetries. And the stiff eye has the lower progression of mean total deviation. This is the first time we see the relation between the cornea and the progression of glaucoma. And she also said that maybe there are relations between the stiff of the cornea and the stiff of the sclera. And the biomechanical maybe show us that the ability of the sclera to absorb pressure. This is the results of the CorvisST in a printout. We see that the red lines is the results of the patient, and in the and the red light is the normal population. And if the red eyes is inside the red light, the patient has normal value. And it's easier for the general ophthalmologist to do in the practice. Because the dynamic corneal response parameter is so complicated, so the CorvisST provides three more simpler parameter that easily to apply in the clinical practice. The first parameter is BIOP, biomechanical corrective pressure. We all know that Goldman tonometers is affected by the inside IOP. The central corneal thickness mostly changed after the refractive surgery, and the biomechanical properties of patient it will change with age, change with the time of use of prostaglandin eye drop, and with the time of high pressure. And this is the formula. We see that it's very complicated, but we see that we have sensitivity here, we have pressure here, we say age here, and we have dynamic corneal response here. With 19 constant from A1 to A19, the final results, the BIOB is not affected by all these factors. So the BIOB is independent with age, with CCT and corneal biomechanics. And we can use BIOB. I think the BIOB is more accuracy than Goldman tonometer in patients with after the LASIK surgery, cornea surgery, and in patients with abnormal corneal biomechanics. This is a research from Korea, Dr. Hunley. He compared the pressure before and after the LASIK surgery, and he used different machines to measure. In the group of IOP non-contact tonometer, there is the significant difference between the post-operation and pre-operation IOP. But in the BIOP group, there's no difference between pre-operation and post-operation. So BIOP may be the new method to measure the pressure after the corneal surgery. The second parameters I want to say this afternoon is SPA1, stiffness parameter. Stiffness is defined the change of the change of the shape with force. With cornea, we have two forces: air pressure and intraocular pressure with opposite direction. And the change in shape, the displacement of cornea is the deformation amplitude. So, if we this is the formula of the SPA1. The air pressure at the first applanation minus the BIOB, it releases the actual pressure that affects the cornea, and the A1 deflection amplitude is the change of the cornea with pressure. So this SPA1 is the stiffness of the cornea, the stiffness of any material. So the SPA1 is shows the cornea ability to absorb the pressure. In clinical practice, the CorvisST shows the SPA1 with another value like BIOP, CCT, DA ratio, etc. And the black line is the results of the patient, and the gray areas is the standard deviation. From now, if we know the ability of cornea to absorb the pressure, we also know the ability of sclera of the lamellar fibrous cell to absorb the pressure. And it's very interesting in research about the glaucoma and normal tension glaucoma. The final parameter is biomechanical glaucoma factor. This is a new approach to detecting normal tension glaucoma. The machine is based on 5 parameters: DA ratio, highest concavity time, bathymetry slope, BIOP and CCT. And this is the formula of the BCF. Dr. Karin Pilunas used these parameters to diagnose the patient of normal tension glaucoma and see and he see that BCF have sensitivities and specific to discriminate healthy from normal tension glaucoma with 76% of sensitivity and 77% of specificity with the cutoff value of 0.5. So the normal eye has a BCF lower 0.5, whereas the normal tension glaucoma has the BCF higher 0.5. This is the glaucoma screening software of the machine. We see that this as the IOP follow-up in every single visit. This is the BIOP. This is the distributions of BCF parameter in healthy, green zone, and in normal tension glaucoma, the red zone. And black line is the value of the patient. If the black line is in the red zone, the patient maybe have a risk factor to progress to the normal tension glaucoma. In summary, we see that the new machines represent us all new parameter, dynamic corneal response parameter relating to corneal biomechanics. And we, in clinical practice, we have three important parameters. BLB is not affected by age, by CCT, and by biomechanics of the cornea. SBA1 shows us the ability of cornea to absorb pressure and maybe the ability of the eyeball wall and lamina cryosa to absorb the pressure. And finally, the BCF is an independent risk factor for normal tension glaucoma and can be used to screening for normal tension glaucoma. This is my university and this is my hospital where I working normal practice in every day. Thank you.
Thank you, Professor Nguyen. You certainly opened our eyes as far as the interrelationship between corneal characteristics and IOP measurements are so much in close connection with each other. You know that as a glaucoma specialist, our world revolves around intraocular pressure, and we have always been trying to look for a way as to how best we can measure it. I mean, in the truest sense, the only way to measure true intraocular pressure is by sticking in a manometer into the anterior chamber of the eye. But we all know that that is not practical. And by introducing to us the technology that is offered by Corvis, we now are able to approximate even better what true intraocular pressure is. And that is simply because we now take into consideration all the biomechanical factors that are possessed by your cornea and how they will affect the actual reading of intraocular pressure. And therefore, by being able to really accurately record what true intraocular pressure is, we may be able to understand what is actually happening in our patients, guiding us as far as treatment and monitoring is concerned. So thank you very much for that.
Yes.
Thank you, Aquino. Thank you very much.
Thank you, Dr. Nguyen. It's really eye-opening, and I'm sure many of us have had patients whose, although their IOP has been controlled, they continue to have worsening of their visual fields, and this probably explains that. And it's a real boon to us to have a tool like this to be able to figure out what's happening. Okay.
And in these times wherein there are so many corneal altering procedures, LASIK, corneal transplantation, to a glaucoma specialist or any clinician for that matter, taking the IOP is so challenging. You do not know whether that patient is already developing complications of secondary glaucoma. You do not know whether that patient already has elevated pressure, but is not being recorded because of the alterations in corneal characteristics. So again, I emphasize the fact that with this modality, maybe we are opening doors for even safer and better practice among our patients.
And to add to the safety, in the time of COVID-19, it's a non-contact type of tonometry. So it's much better or much safer than a Goldman.
I would agree. I would agree. Yes.
Yeah. Okay. We're receiving some questions on the YouTube comment section, and let's look at the first one. And this is open to all the previous three speakers. So I guess this is for both Tina and Corina. Can dry eye affect the accuracy of the Belin Ambrosio elevation data?
That's a good question, sir. Because as we discussed in our first episode 2 weeks ago, Scheimpflug imaging actually is less affected by an abnormal ocular surface as compared to the traditional Placido disc topographer. But there are actually some reports already out there studying the effect of dry eye on elevations in the body display. And some reports, some journal articles are actually saying that it could cause some false elevations on the body. And also, dry eye can affect pachymetry results. So, just like I said in the first episode, if you have a patient who has dry eye, it would be better to treat it first, especially if that patient with dry eye is coming up with abnormal readings on the body. It would be good to treat the dry eye first and then repeat the measurement and see if it changes.
Well said. Well said.
Let's see. All right. The next question is, how do you define progression using the ABCD progression display? How many parameters should reach the 95% confidence interval and or the 80% confidence interval?
I think that's for Tina.
Tina, all right.
So as we mentioned in our lecture, we define progression with the ABCD progression display when you hit the 80 or 95% confidence intervals. And you have two groups. You have the groups that are very early or subclinical keratoconus, and these will more likely follow the normal population confidence intervals, which are in green. And the other group, which are the more advanced stages of keratoconus, will more likely follow the keratoconic population confidence intervals. So you just have to follow or look which stage the patient is in, and then see if the patient already crosses the 80% or 95% confidence intervals. So with regards to how many parameters should reach 95% or 80%, we don't really have a fixed number of parameters that are needed. It really depends on the entire clinical picture of the patient. So it depends on the patient's age, if the patient's young or old. It also would depend, maybe the most significant parameter for this would be your posterior corneal surface. Since we know in keratoconus, one of the first things that changes is your posterior cornea. You can have a normal anterior corneal surface, but the posterior cornea is already steepening. So the parameter that I would look at the most would be parameter B, or the back surface or posterior surface, because this is the first thing that changes in keratoconus progression. And then later on, you'll have corneal thickness, and then the last parameter most likely would be your anterior corneal surface. And
well, just a follow-up question, Tina. So this might be a stupid question, but all those parameters, when you ask for a test, you don't have to specify them, right? You just have the test, and then it will just come out in the display.
Yes, sir. Everything is there. The machine will just take one examination per follow-up, and then all the parameters will be displayed on the screen. So you don't
Do you have to ask for a certain panel or a certain display?
You just have to ask for the Belin ABCD progression display, sir.
Perfect. Okay. Next. Yeah. What is the recommended time interval between tomography tests to monitor ectasia progression? So basically, how often can you ask for them?
It would really depend on the population or the kind of patient that you're screening. So the patients can be divided into two. So we have the high risk group and the low risk group. High risk group patients are those patients that are very young, those patients that are less than 20 years old. So they say that these patients who are younger have a higher risk for progression, and they can actually progress 2 to 4 months after the baseline examination. So for these patients, when you detect the progression on first examination, I don't think you really need to document any progression anymore, especially if patients are young, maybe when they're in their teens, when they're 15, 18 years old. You can already um, you can already try to do cross-linking, because if you wait to document progression, then when the patient comes back, there's already a huge progression change. But for patients who are of the low risk group, those patients who are older and have no family history, don't really rub their eyes, you can wait maybe around 3 to 6 months or 6 months or more for follow-up to document progression.
Okay. I think it's time now to move on to the next segment. But before we do so, let's listen to another message from Oculus. For our next guest, I'm very happy to introduce a very popular and very much in demand speaker around the world. I'm also very honored to call her my friend. Professor Shizuka Ko received her MD from Osaka University Medical School in 1999. She did her research fellowships at Osaka University and at University of Rochester in New York. Professor Ko has pursued quality of vision in corneal and ocular surface diseases and focuses on the following research topics: visual function, dry eye, corneal diseases, keratoconus, corneal ectatic diseases, and contact lenses. Professor Ko is currently an associate professor in the Department of Innovative Visual Science in Osaka University Graduate School of Medicine. Given her expertise, Professor Ko is in a perfect position now to tie together the concepts of our previous talks. Without further ado, we now give the floor to Professor Shizuka Ko.
Yes. Okay. Thank you for your kind introduction. Good evening, everybody. It is my great pleasure to be, a great honor to be invited here and give a talk today. I'd like to thank Professor Caparas, his wonderful team, and Oculus for giving me such a great opportunity. Let me start my talk. Okay. I hope you enjoyed the introduction. I am so happy that today's webinar is exactly episode 4. So in my talk today, first I will talk about corneal biomechanics and its role in ectasia. Then I will talk about joint use of the Pentacam and Corvis for ectasia detection and monitoring. The cornea is not a piece of plastic. This is a very famous phrase by Professor Cynthia Rovers, who has made a great contribution to the field of corneal biomechanics. The cornea exhibits both viscous and elastic biomechanical behavior. Elastic is usually used for solid. It is the ability of a body to change its shape when the force is applied and to return into its original shape when the influence of the force is removed. Viscosity is generally used for liquid. It means a measure of its resistance against progressive deformation. Oh, sorry. What is stiffness? It is overall rigidity of an object. Stiffness is defined as a measure of the resistance against elastic deformation as a response to the applied force. It is dependent on several factors. Let's think of a basketball and a beach ball as examples. I heard that basketball is the most popular sport in the Philippines. When we think about their stiffness, we should consider material, thickness, and internal pressure. Material of these balls are totally different. The basketball is hard and not easy to deform, but the beach ball can deform easily. When we compare the ball with the same material, stiffness is higher in thicker balls or balls with higher internal pressure. When we think about cornea, material in cornea means corneal biomechanics. Thickness is, of course, corneal thickness. Internal pressure means IOP. So stiffness of the cornea is dependent of corneal biomechanics, corneal thickness, and IOP. Keratoconus is transparent corneal disorder where the central or paracentral cornea undergoes thinning and stiffening. As you know, it is sometimes difficult to diagnose in relatively mild cases. This corneal thinning typically causes irregular astigmatism, leading to mild to marked deterioration of visual acuity. The most important thing is that keratoconus is progressive. So progression prevention should be considered. The pathophysiology of keratoconus is likely includes the following components: genetic, biochemical, biomechanical, and environmental disorders. What is corneal ectasia? Corneal ectasia is biomechanical change of the cornea, leading to thinning and protrusion of the cornea. Also, it leads to a progressive astigmatism with irregularities. If it progresses strongly, possible keratoplasty or potential blindness might be considered. This is a theory of development of ectasia. Before corneal curvature or thickness changes due to the disease, the corneal stiffness and elasticity is already changed. Therefore, measurement of biomechanical property is crucial for detection of subclinical ectasia. As clinical significance of corneal biomechanics, I can mention following things. Assessment of accurate IOP is helpful for consideration of glaucoma risk factor. Regarding to keratoconus and ectasia, it is useful to detect subclinical status and to monitor progression and efficacy of corneal cross-linking. Corvis is a novel non-contact tonometer that allows investigation of the dynamic reaction of the cornea to an air impulse. It is based on ultra-high-speed shine-proof technology. Shown here is the obtained movies from normal eye and keratoconic eye. You can notice the difference. This is a dynamic corneal response display. Several parameters are shown. Shown here is Vinci-Guerra screening report. At the bottom right of the screen, there is a box with 5 parameters. These are first 4 parameters, and colored one at the right end is Corvis Biomechanical Index, CBI. This is calculated based on the corneal thickness profile and deformation parameters. Let's take a look at these parameters a little bit more. We already had a nice lecture about some parameters today, but I believe that most of you are not familiar with them or got to know for the first time today. So don't worry, I'm not a physics teacher. I am going to explain them very simply as a clinician. So except for ARTH, ambrosial ray natural thickness horizontal, other 3 parameters are purely biomechanical parameters. We will focus on these 3. DL ratio, deformation amplitude ratio 2 mm, is calculated based on the ratio between the deformation amplitude at the corneal apex and the deformation amplitude at 2 mm nasal and temporal from the apex. Softer cornea start to deform only in the center, where the paracentral part of the cornea deform much less. Therefore, the DL ratio is higher in softer corneas than in stiffer cornea. The central radius of curvature is calculated during the concave phase of the deformation. Softer cornea exhibits smaller radius, so the inverse radius is higher. The area under this inverse radius versus time is determined, and it is called integrated radius. Thus, the integrated radius is higher in softer corneas than in stiffer corneas. Stiffness parameter is calculated based on the difference between the strength of the air pulse at the center corneal surface and the biomechanically corrected IOP, BIOP. The displacement of the corneal apex at the time point of first applanation is measured. Therefore, the stiffness parameter is lower in softer corneas than stiffer cornea. Again, CBI, Corvis Biomechanical Index, is calculated based on the corneal thickness profile and deformation parameters, and it ranges between 0 and 1. It is useful for detection of clinical and subclinical keratoconus. Let's quickly revisit tomography. When you read tomography, you begin with ABC. Yes, A for anterior surface, B for back surface, C for corneal thickness. Now you understand that the softer cornea has higher values in DA ratio and integrated radius, and lower values in stiffness parameter. So, do they correlate with the severity of keratoconus? Recently, we investigate the correlation between corneal biomechanical parameters and severity of keratoconus based on tomographic parameters. Yes, ABC. Yes, these are biomechanical parameters, the ratio, IR, and stiffness parameter. And this is A, B, C. So, and CBI beta is kind of raw data of CBI. Instead of values between 0 to 1, it shows real values. As you see here, they are all well correlated. Therefore, biomechanical indices correlate with keratoconus severity. As one of the updates, biomechanical comparison display is newly introduced. It can provide visualization of biomechanical changes over time. It is useful to track patients, especially pre- and post treatment. Let's move on to the next part. Keratoconus generally presents bilaterally, although often asymmetrically. If you are not a corneal specialist, I'm not sure if you've ever heard this term before, firm first keratoconus, FFKC. FFKC is defined as a cornea that has no abnormal findings by both slit lamp examination and placido disc corneal topography. The same person has clinical keratoconus in one eye and apparently normal fellow eye. However, there is no consensus on the definition of FFKC right now. According to the global consensus on keratoconus and ectatic disease, true unilateral keratoconus does not exist. However, a unilateral clinical presentation may occur. You cannot say unilateral keratoconus, but unilateral ectasia is fine. The recently introduced tomographic and biomechanical index, TBI, combined Scheimpflug-based corneal tomography and biomechanics. It can enhance ectasia detection. This is a case of very asymmetric ectasia. As you see, this is the ectatic eye. In this display, BAD D from Pentacam and CBI from Corvis and TBI combined parameters from Pentacam and Corvis are shown. Both CBI and TBIs are ranged between 0 and 1. So this is actually typical clinical ectasia. All the values are very high. Now this is his fellow eye. Very asymmetric ectasia with normal topography. Placido disc corneal topography and wavefront did not show any abnormal findings. Okay, both BAD-D and CBI are low values and within normal range. However, only the TBI was abnormal based on the cutoff values. Subclinical ectasia was detected only with TBI. We may call such kind of eyes as a very asymmetric ectasia with normal topography and normal tomography. Recently, several papers from the different countries reported that TBI was useful in detecting subclinical ectasia in eyes with normal topography. Let me share with you our TBI validation study in Japanese population. So we compare the BAD-D and CBI and TBI among the four groups: normal, clinical keratoconus, ectatic eyes of very asymmetric ectasia, and fellow eyes of very asymmetric ectasia. As you see, in the VAE with normal topography, compared with BAD-D and CBI, TBI showed variations compared with other parameters. In your study, 60% showed abnormal values at least in one parameter from BAD-D and CBI and TBI. However, 40% showed all normal values. Probably these cases may be unilateral ectasia. Therefore, I could say that TBI may allow separation of true unilateral ectasia from true fluid cases. Let me mention PRFI, Pentacam Random Forest Index, as one of the updates. Then what is random forest? Random forest, like its name implies, consists of a large number of individual decision trees that operate as an ensemble. Each individual tree in the random forest spits out a class prediction, and the class with the most votes became the model prediction. PRFI is a random forest model built using data from the Pentacam HR. It is indicated here. The recent International Multi-Center study reported that the PRFI enhances ectasia diagnosis. I believe that we will see further advances in this field. Another topic is laser vision correction and ectasia. As you know, laser vision correction is a widely accepted procedure to correct refractive errors. Generally, it provides excellent safety profile. However, in a small amount of cases, iatrogenic ectasia can develop. Then, how can we assess cornea after LVC? There is no objective criteria. Now, Corvis has a new program named CBI post-LVC. It allows an automatic assessment of the post-operative biomechanical stability. It was developed to differentiate between stable eyes after LVC and eyes that develop ectasia after LVC. The software also detects automatically whether the examined patient has a treated cornea. As a final output, the CBI LVC estimates the risk of an ectasia after laser vision correction. Like CBI, it ranges between 0 and 1. So this is a case of post-LASIK ectasia. The CBI LVC values is 1.0. This is a stable case after LASIK. CBI LVC is very low. Please note that in this CBI post-LVC display screen, body and TBI are grayed out because these are no longer usable on post-LVC patients. According to the recent multicenter study data from my good friend, Dr. Ricardo Vinciguerra, actually I am also part of this study. If the status of post-LVC is known, it can tell ectasia or stable with more than 90% accuracy. If the status of post-LVC is unknown, 90% of cases were correctly classified into normal, keratoconus, or ectasia after LVC, or stable after LVC. These 4 groups. Okay, let me share with cases from our clinical practice, not in a galaxy far, far away. When the patient is referred for refractive screening, we normally do everything. In addition to standard exams, we do topography, tomography, biomechanics, wavefront, OCT. Multimodal imaging is helpful in diagnosis of borderline cases, especially. Also, we perform the questionnaire for keratoconus-related risk factors. Shown here is my current cutoff values for normal. So this is a very asymmetric ectasia with normal topography. As you see, only the CBI was abnormal in red. In such case, we keep observation. We experience such cases where CBI at only one visit was abnormal. Yes, we keep observation. This is a follow-up case of very asymmetric ectasia. So as you see here, no significant topographic change was detected in the fellow eye. So this is the also for fellow eye. So this is the ectatic eye. You can see the definite clinical keratoconus, but this eye has no abnormality based on the placebo corneal topography in 2018 and 2020. Follow-up with normal topography is very important. So this is his first visit in 2018. And 6 months later, 1 year later, and this is the latest visit, February in this year. It looks like this eye seems like unilateral ectasia. There is no abnormal values in body, CBI, and TBI so far. But we definitely need the observation. So this is another follow-up case of very asymmetric ectasia. His first visit was in 2014. No significant topographic change was detected in the fellow eye. This is 2014, 2017. So this is the Pentacam measurement as the first visit in 2014. So this is a measurement result in 2017, and 1 year later and 2 years later. Okay, so unlike the previous case, this eye looks like a subclinical ectasia. All the values from body, CBI, and TBI are normal. Even placebo topography are all fine. Let me share with you interesting cases. 14 years old male was referred as suspect keratoconus. He had high astigmatism in his both eyes, here and here. He reported no keratoconus-related factors. No abnormality was detected in both eyes based on the placebo topography, as you see here. So, so in his both eyes, body, CBI, TBI, all the values are within the normal ranges. So no abnormality was detected. So we consider him as with the rule astigmatism. But of course, we also ask him to come back 1 year later. So far, he is still with the rule astigmatism. So this is the case of a 14-year-old female. He reported eye rubbing at P. No abnormality was detected in both eyes based on the placebo topography. So, so these ARV displays, body, CBI, and TBI, all the values looks like normal. So we may consider this is normal. But actually, her mother is clinical keratoconus. Her mother, one day, her mother, when she came for the regular exam, he actually asked me to screen her all three daughters, aged 18, 17, and 14. So this is our first daughter. Based on the keratoconus screening program with placebo topography, so this is right eye and left eye. So the first daughter had keratoconus suspect in the left eye, you can see. So this is the second daughter. So placebo topography, the right eye looks like normal, but the left eye, placebo corneal topography detected keratoconus in the left eye. So this is the third daughter, which I showed just before. Considering her familiar background, high susceptibility for ectasia might be considered. Therefore, it is totally different from the first case, 14 years aged boy. We cannot consider this girl just with the rule astigmatism case. Generally, FFKC might refer to the fellow eye of a manifest keratoconus that has no clinical sign or any significant topographic change. But I think that the term bilateral FFKC could be proposed, especially for this case. However, definitely we need long-term follow-up. Many teenagers are referred as suspect keratoconus for further examination since they have high astigmatism or from other reasons. Consideration of keratoconus-related factors such as familial history, eye rubbing, sleep face down, atopy, and ocular allergy is very important. Eye rubbing and sleep face down, we should definitely educate patients. And for atopy and ocular allergy, we can manage. Especially, this is important because keratoconus progression seems to be aggressive and rapid compared to the elder age groups. Dr. Renato Ambrosio in Brazil is actively working for keratoconus awareness campaign named Violet June. If you go to the website of Dr. Damien Gatinel in France, you can find the keratoconus diary. Both doctors emphasize the importance of patient education. Stop eye rubbing. Okay, this is my take-home message today. Thank you very much.
Thank you,
Thank you.
Professor Ko. That was such an informative, thorough, and I must say, very cute presentation that you gave us this afternoon. All right. Now, maybe it is again time for us to open the floor for any questions our audience might have.
So I think the first question we can throw to Professor Ko, or maybe Princess Leia. Have ethnic and age-related differences been observed in corneal biomechanics measurements?
Okay. Thank you for the question. Okay. I believe definitely there should be some differences. So as far as I know, there is no report. I think to study the difference in corneal biomechanics among the ethnicity. But if we think about the difference, I think definitely there is some difference in corneal thickness between the Asian eye and European eye. Yes, I think this is very interesting topic we should actually consider.
Yeah. So you think we each, I would say maybe country, maybe not country, but maybe like ethnic origin should have some normative data?
Yes, maybe, yes. As even in Asia, maybe actually Northern Asia and maybe south part of Asia might be different. I'm not sure, but maybe I think it is. We should actually maybe do some collaborative study as well.
Yeah, I think so. Maybe we should collaborate.
Yes.
Okay.
Again, this question goes to the cornea people in this session. Can the sensitivity and specificity of the proposed cutoff values for BAD, D, CBI, and TBI vary between ethnic groups?
Can I answer?
Yes, sure.
Yeah. Actually, we actually did the TBI validation study based on the previous study or already done study in European countries, and actually definitely I think the percentage of kind of unilateral ectasia is actually looks like higher in our actually Osaka University compared with other studies. But definitely we need much more data because, as you know, FSKC is kind of rare. So we should need more actually large number of FSKC patients. And actually we are also very I'm also interested in actually to look at the data collect the data from Asia. Maybe it might be some difference between some countries, but yes. I think this is still actually we need a kind of adjustment.
I would like to throw a personal question to Professor Nguyen. All right. Again, for the glaucoma people, I would like to know, have there been any comparisons between the Corvis and the more popular or more commonly used IOP measuring machines like the Goldman and maybe the dynamic contour tonometer, which is, I think, another technology that also inputs corneal characteristics? Would you be aware of any comparisons or validations between or among these machines?
Yes, thank you, Dr. Aquino, for your question. I think, as I showed you before in my presentations, the CorvisST use a formula to differentiate every factors that affect the pressure, including age, CCT, biomechanical properties, and the pressure inside. So up to now, I think the BIOP is the only way to measure the pressure inside the patient after the cornea surgery accuracy. And compared to the Goldman tonometer or F tonometers, I think is better. But I don't have the data to compare the BIOP with the dynamic control tonometer, as you mentioned.
I asked this question maybe because it would be very interesting for all of us to really be convinced that using a Corvis has more advantages than your regular Goldman applanation tonometer. All right,
Yes,
and since the Corvis has not really, I have to be honest, entered the consciousness of the average clinician,
yeah,
it would be very nice to convince them that it may offer more advantages than what they are used to using.
Yes.
So maybe that is an area that Oculus or the different Asian regions can do common work in to really see how this new technology can be put to better use.
Yes. When I do CorvisST, we use CorvisST in clinical practice. I see that it's very easy to use, better than Goldman tonometer, because Goldman tonometer we must contact the cornea. And the second benefit of CorvisST, I see that we find out the stiffness of cornea. And I'm most concerned the stiffness cornea because the stiffness cornea may be related to the stiffness of sclera. As I can explain many reasons. Patients that has normal IOP, normal CCDs, but they has glaucoma optic disc. And so I think a softer cornea has a softer sclera, and we must to reduce the pressure in that patient, to protect the optic nerve.
We have a follow-up question, Dr. Wen. Yeah. And I think I'll throw this to Dr. Aquino as well. Norman, we have collaborated a lot on post-PKP patients with glaucoma.
Correct.
And so the question that has been posed here is just right up our alley. So how does the CorvisST account for the IOP in the corneal grafts post-PKP? I guess what they're saying here is, how do you explain the kind of IOP that you're getting when your cornea has actually been replaced?
Yes. As my presentations, we have research from Dr. Hunley from Korea, and he's compared the pressure before and after the PKP procedure. And he found out that with Goldman tonometer, there's a significant difference before the pressure, pre and post operation. But with BIOP, the result is the same. I think it's the patient with post-PKP procedures, we must use the CorvisST to evaluate the pressure.
Vic, one of the biggest challenges for me is to take the IOP of a post-PK patient, whether it be day one post-PK, when there is so much corneal edema and swelling, whether it be 2 years post-PK. You really never know the accurate measurement. Whenever I deal with these patients, I basically throw whatever I have at them. I take an air puff measurement, I take a Goldman applanation measurement, I take a tonopen measurement simply because of the smaller tip that hopefully will give me a better idea of the actual pressure when I touch it to the center of the cornea. But there are times that I don't even believe any of those three, and I rely on my 2 forefingers in trying to just depress the sclera and see if that eye is hard or fair. And that is why I myself would be very interested in gaining some experience with the Corvis for me to really see how good it is and how valuable the data it will give me.
Well, we have another question here, and I think we can throw it to all 3 cornea lecturers. As a parameter for detecting ectasia, is TBI influenced by the central corneal thickness, the IOP, and the K values. So anyone can jump in.
Yeah, I can make some comment.
Yes.
But because TBI is actually a combined parameter from tomography and biomechanics, I think definitely actually influenced by CCT. CCT as a, because CCT is also actually measured by tomography, and of course IOP is also IOP affect TBI as well. But I don't actually do any study data. And K values, I'm not sure this question actually means that K values only from anterior. But recently, I don't think a parameter like K max is not a real actually gold standard one. Previously, it was gold standard, but right now, K-Max is not a real gold standard, I think.
Isn't not the BIOP actually already corrected for the IOP?
BIOP is actually,
Yes.
yes, I think real one,
Yeah,
yes.
yeah. That's right. Okay.
All right.
I think we've exhausted our questions.
Correct. And
Yeah.
at just the right time.
Yes.
So we'd like to thank everybody for all your questions and the learning that have resulted from all of them. Before we end, I'd like to remind the audience to not forget to fill out the attendance and the evaluation form posted in the comment section of this presentation. So I would like to thank all of you who tuned in and attended for joining us. It is Dr. Caparasis and I and the TMC's hope that today's session was very productive for all of you. We graciously thank our esteemed speakers, Professor Ko and Professor Nguyen, for sharing their time and knowledge, and of course, for our reliable Dr. Samaniego and Dr. Tan for helping us through the Pentacam. We, of course, would have to thank Oculus for partnering with us once again, and we look forward to bringing more lectures to you via this venue. All right.
Yeah. And for the next episode of EyeTV, we're going to take a short break from talking about the cornea as we invite our pediatric ophthalmologists to present an episode all about accommodative spasm. So please tune in again as we go live on July 30th. That's again a Thursday at 5 p.m.
Mm-hmm. So to get notified for these new videos, go to the YouTube channel and just click on the subscribe button below and you will see this episode, all right?
So I'm Vic Caparas.
And I'm Norman Aquino. And I'd like to thank you for watching this episode of TMC EyeTV, continuing or combining the CorvisST with the Pentacam, assessing intraocular pressure and corneal ectasia and biomechanics. Thank you, everyone.
Thank you. Thank you for all being part of EyeTV, and we hope you'll join us again for Ophthalmic Instruction Without Borders. Good evening, everybody.
Bye-bye. Bye-bye.